Our next speaker is the Chief Perfusionist at Children's Hospital of Philadelphia. She's the AMSEC current president, secretary of the Academy of Cardiovascular Perfusion, and her interests include blood conservation, circuit miniaturization, and quality improvement. She will be presenting Integrating New Technology to Improve Patient Safety and Perfusion. Please join with me in welcoming Tami Rosenthal.
Thank you. Thank you for the warm welcome, and what a presentation to follow. That was spectacular. So my goal is to start out with a few polling questions. I knew there would be a few technical difficulties, so we're going to give these guys just a second to get this up and running.
Give us a minute. We're missing the adapter.
Okay, well, we can maybe get started with it. What Luke is helping me with is to get it up on the screen so everyone can see it. But if you open up your app, your meeting app, and you go into the agenda for today and scroll down to my presentation, Integrating New Technology to Improve Patient Safety and Perfusion, 115. And then once you're there, you'll see right underneath the stars, it says polling. And if you click on the polling, you will see the 4 questions that I'm looking to ask the group today. So the first question is, are you aware of the AMSEC standards and guidelines for perfusion practice? I'm really hoping we get a really high number here. The second question is, have you read the AMSEC standards and guidelines for perfusion practice? So you might be aware of them, but have you actually had the chance to sit down and read through them? It's looking pretty good so far. And then the third question to do with the standards and guidelines is, have you implemented any of the standards and guidelines into your perfusion practice? And this is the one that I'll be really curious to see where we stand with this.
Sorry about that.
That's okay. Looks like we're still getting some increases in votes, so we'll just give it a minute here. Ah, fantastic. Okay, great.
You can scroll.
Okay.
Yeah, sure.
Okay, cool. All right, so we're up at 86 responses so far. Oh, and the online crew also can access this through your app as well. We definitely want responses from everyone. So at this point, we're up to 85% yes out of 89 respondees, which I think is strong. And then for those who've actually sat down and read the standards, we're at 70%. I'm really hoping the 29% will feel guilted enough to read them this week. And then as far as implementation, which as we know is a lot more challenging, we're at 59% yes, which I think is very good. And then the last question, and you'll see that this is relevant to technology and my presentation. How do you record your cardiopulmonary bypass record or chart? And I know that in the pediatric population, I think we were a little ahead of the curve, and many pediatric centers are electronic, and I know the adult perfusionists are trying to catch up as well. So I did expect a split here, and that's what we're seeing, 45% written on paper and 38% electronic charting. So we're still a little heavier on the written versus the electronic. And this is actually broken down into 3 different responses, electronic and automated. So there are those that are using the database where you are electronic, but you're manually entering, or those where everything is just flowing right into your electronic chart. So 44 for written, 40% for electronic data entry, and 14 for automated electronic charting. So I think if we did this poll 5 to 10 years ago, we would have been majority written and hardly anyone electronic. And now I see that at least we're moving in the right direction with some manually entering electronic and the smaller percentage automated. So that's great. Well, thank you very much for participating in the poll. So integrating new technology. My disclosures, I have no financial disclosures, but I will admit to being an early adopter. Back in my younger years, I wanted to be the first one. Now I'm okay being like the second or third, but I'm definitely going to be trying something when it comes out to market. And you'll see that that's a big part of implementing technology. And I'm a pediatric perfusionist. Can I see a show of hands of the adult perfusionists in the room? Okay, great. Don't worry. This is going to be relevant to you as well. A lot of the technology that we're rolling out is going to help adult and pediatric perfusionists. So when I think about integrating new technology for perfusion, there are 4 major focus areas where I think we can make the biggest difference. Minimizing the bypass circuit to decrease blood transfusion, monitoring during bypass so that we can measure the adequacy of perfusion with new information that we didn't have in the past, electronic data capture, which is why I was asking those polling questions, because this is going to support perfusion and surgical databases, as well as quality indicators, which we can use on bypass and retrospectively, but the electronic capture is really going to enable us to do this. So let's talk about best practice, the why we do things. In this article stated by Sackett and Group, they talked about evidence-based medicine. And what is that? Integrating clinical expertise with available external clinical evidence. And this is what we should be making our practice decisions upon, not the way we've always done it or what we think might be most beneficial to the patients. So when we talk about the standards and guidelines, these were developed by the AMSECT group, the ICEBP. And I think this is a workhorse group, the International Consortium for Evidence-Based Perfusion Practice. And this committee has been around for a very long time, but I think that they've always been in the background. And I really want to give them credit for the work that they've done to develop these standards and guidelines. And then for the pediatric guidelines, I want to credit the Pediatric and Congenital Committee of AMSECT as well. The adult guidelines were just updated this year in 2023. They were approved. And the pediatric version came out in 2019, and they're due for a revision this year as well. So starting out with minimizing the bypass circuit, Standard 12 circuitry states that the perfusionist, the print is a little small, the perfusionist shall select circuit components taking into consideration prime volume, surface area, and safety. And I will say that pediatric perfusionists have had a focus on this for quite some time. We have such a wide range of patient kilogram weight, size, anomaly, that we've really worked to customize our circuits to the smallest we can for our patients. In the adult guidelines, this is actually listed in blood management, and it states something similar. The perfusionist shall minimize the cardiopulmonary bypass circuit size to reduce prime volume. And this has become a lot of the work that's being done in adult perfusion as well. So looking back 30 years ago, you can see we've come a very long way. This is very dramatic. Our circuits were large, they were sitting on the floor, we were very far from the patient. And now with the technology that we have available, we are higher, closer to the field, and we're really able to customize our circuitry. Looking a little bit at the literature, it has been recognized the significance of decreasing prime volumes. to incorporate these values into our practice. The literature in pediatrics is scarce. For example, there's no universally accepted critical DO2I threshold, whereas in the adult practice, it's really been well established. This is really continuously evolving, and we need to be open to changing our practice and not just holding on to the way that we've always done things. We now have the option for a more comprehensive way to determine perfusion accuracy. We no longer are just looking at our pressure, our SpO2, or even our lactate. So monitoring in real time is what provides the greatest value, and this is how we can do it. As you can see, there are a number of different options that you can incorporate into your practice. Estimation of regional oxygen saturation has also become a best practice in the adult world and is widely accepted in the pediatric. And this information added to our standard blood gas and some of these newer values increases our knowledge of perfusion adequacy. So when we talk about monitoring, that leads us to goal-directed therapy. And as in this article by Metaconda, they talk about the recent paradigm shift in pediatric perfusion management. And what he states is that these clinical parameters can be tailored to perfusion for each specific patient needs. So we're looking at all these goal-directed perfusion parameters, and we're tailoring them specifically to each patient. In a commentary on this article, Ron Angona highlighted that for many years, pediatric perfusionists have had individualized care plans, and that this increase in monitoring technology allows the availability of real-time data. And he really highlights that this transition point to electronic data capture and what it can do for the care that we give our patients. So in order to incorporate these values into our practice, we know we not only need to be able to measure them, but we need to be able to capture and visualize them in real time. So ideally, these points, these data points would be captured every minute or less, and then entered into national and international databases. As you could see by the ARS poll that we started out with, there are still many institutions that are using handwritten records, charting every 10 or 15 minutes, so this really becomes challenging. When I first broached using electronic data capture to my team and to some of the other perfusionists that I know, everyone was really concerned about the legal aspect. You know, what happens if, you know, at the moment I'm supposed to be charting, my numbers are down, you know, from a written perspective, you're gonna write, you know, what numbers you want to write, but when you're electronically capturing them, if the surgeon tells you to go down on flow and that's the second that the information is captured, you know, that's the picture that's going to be in the chart. But what perfusionists need to get on board with, and it seems like we're heading in that direction, is that it's about the whole clinical picture. There are ways to document the surgeon told me to come down on flow, or, you know, the cannula popped out, or, you know, whatever is happening in that moment, because we need to have the full clinical picture, and that means the electronic data capture. So when we talk about this electronic data capture, we need it to be comprehensive. We need it to be integrated with our heart-lung machine. We need the data entry to be minimal. So we want to have a lot of drop downs, hot buttons that we can push. We don't want to be doing any manual entry of different phrases so that we can really standardize. And we need it to be integrated into the patient's EMR. We want the ability to display this real-time data of these newer values, and we want to allow for the opportunity for quality assurance and quality improvement. Here you can see some of the current options. There are specific perfusion vendors that will provide you the database and the service, and then you can have the connectivity to the patient's EMR. And then there are those where you're actually in the patient's EMR and they direct connectly, and that information already lives. And so there are a couple different ways we can do it. And in some institutions, you have to use the enterprise solution. Others, you have more of a choice whether you want to go with a perfusion vendor or the enterprise solution. So once we have incorporated this electronic data capture into our practice, where do we go from there? Well, historically, and in many institutions, data is manually entered for our databases. Specifically, what comes to mind is STS. After our case, we're sitting down, we're doing our data entry, Perform, PD Perform, PC4, PAC3, all of these automated multi-institutional databases, it's important for us to participate in. So if we have automation with it, we can minimize our errors, we can improve our accuracy, and it's going to give us a break. We won't have to sit down after our case and enter all of this data. So here are some of the examples of the companies that do this data automation. At Children's Hospital, we use Cardio Access. We have for many years. All of our data entry went into Cardio Access and then would automatically go to STS. And then when we got up and running with Epic, we were able to make that connection between Epic directly to Cardio Access, directly into STS. We have just recently gone live with PD Perform, the new pediatric perfusion database. And luckily enough, we're able to make that same transition. So now when we do our perfusion record in Epic, it automatically goes into our Cardio Access, which automatically goes into STS and PD Perform. Some of these are already in place at your center. It's questions just we need to ask and connections that we need to make that would make things much easier for us. So now we have the access to the data electronically. We want to talk about quality improvement and quality indicators. So the standard number 20 in the pediatric standards and guidelines, the quality assurance, is broken down into two parts. In the actual standard is that perfusionists should actively participate in both institutional quality assurance and improvement programs, and the guidelines are around collecting the data and incorporating them into a registry, and also for quality assurance and quality improvement. And then when we look at the adult standards and guidelines, it is these same 3 action items, but they are now standards. So I do imagine that when the revision of the pediatric standards happens, they will also move from guidelines into standards. I will mention that in the adult new version, they do mention participation in a safety reporting system, such as the newly launched Orem safety reporting system this year that AMSECT has recently partnered with. And this will help provide access to this type of reporting system for perfusionists. So let's talk about quality indicator alerts. Some of the quality work that we do is in the moment, and some of it is done retrospectively, recognizing trends and areas for improvement. But when we talk about quality indicators in the moment, that's where these alerts come in. It's been shown in the literature that they raise awareness, they reduce clinical variability, and they improve quality. So what does that actually look like during a bypass case? What you can see here are the quality indicator alerts that we do use at CHOP. On the left-hand side, you see this red block come up if you're not currently using the system. It's going to tell you what's out of range, and these are ranges you set yourself based on your protocols, and how long you've been out of range. And you can see in our Epic chart, in our actual data lines, the numbers turn red. And it's very visible because you're sitting right in front of it. When I brought this idea of using quality indicator alerts to my group, my institution, after we incorporated some of this new technology, my team was like, Tami, I don't really think I need those. When something's out of range, I see it right away. I have a great loop. I know when something's out of range and I fix it right away. But I think what we found is the technology catches it faster. So if you picture this, you've gone on bypass, you're having some venous drainage issues, your surgeon's questioning, your pressure's a little low, you're having to give neo, you need to get a blood gas off. The scrub nurse is asking you to prime the cardiplegia line, and your surgeon's getting ready to cannulate for cardiplegia. I think you could miss something. And when this red block comes up or these red numbers come up, it's going to show you right away, hey, something's not right, and you can fix it much faster. And then when we're capturing all of this information, we have the ability for this retrospective look for quality improvement. And as you can see here, this is one report that is 1 month's worth of data where you can see the time within or outside of your protocol range. Evidence exists that when quality initiatives are followed, that there's an increase in clinical performance. And thank you. And so here, when we look back at the data, we can say, oh, wow, I really thought I was within range 100% of all my cases. And you can really drill down and figure out what we need to work on. And then here you can see where we break it into different categories, you can compare yourself to other teammates. In some cases, you might want to do this blinded, but if you're willing to share this and compare to your other teammates, there might be a month where one of my numbers is down and I might say to one of my teammates who's doing really well, hey, Molly, what are you doing with X value that you're 100% and, I'm sitting at 80, and you can really learn from each other. And here is the ability to, I relate this to one of my kids who had one really bad grade, and it affected his overall scores, for the semester. If you have one case that was, big redo, you really struggled, you had some issues, those numbers might bring down your total scores for the month or for that section of time. And so it's good to be able to drill down on each case. If you recognize, hey, I had a really tough case last week, and you can pull that up and you can see what it looked like, and you could tell, why your numbers are down specifically for each month. So it's a really great tool. So in conclusion, with a focus on integrating new technology into these 4 areas, miniaturizing with all of our new technology, being able to decrease blood transfusion, monitoring all of these new numbers and ratios to measure the adequacy of perfusion, electronic data capture and automation with databases within your institution and multi-institutional with PD Perform, STS, PAC4, and PC4, and quality indicators, our electronic medical record to access our data and evaluate for goal-directed perfusion and quality improvement. This is where we can make the biggest difference to improving patient safety. We've come a really long way over the last 30 years, and this is how we take perfusion to the next level. Thank you.